Hi, everyone. Welcome to the Injury and Violence Prevention Grand Rounds. I'm going to give everyone a moment to get in from the waiting room, but we're really excited that you could join us today. Um, all right. I'm Kristen Rexing, the Executive Director of SAVIR, the Society for Advancement of Violence and Injury Research. And this is one of our quarterly Injury and Violence Prevention Grand Rounds. And we're really excited about this topic, collaborating to save lives, interdisciplinary pathways, and unintentional overdose. Oops. If you'd like to find out more about SAVIR or Safe States, go ahead and scan. You can sign up for our newsletters and find out more. This Grand Rounds is part of a series of our workforce development project that is a collaborative approach from SAVIR and Safe States. We co-host them quarterly. It's funded by a larger CDC initiative to grow pathways into injury and violence prevention work, or for those working in the field to identify that they are part of this workforce and to collaborate together. These are part of an annual series where we bring together a diverse panel of speakers to address different injury and violence prevention topics with equitable, anti-racist, and multidisciplinary lenses of science, practice, and policy. We like to raise awareness about the field of IVP among students, professors, and professional practitioners, and foster connections within the field of IVP among other diverse fields such as social work, criminal justice, sociology, and many others. We have a few other upcoming events at SAVIR and Safe States, our annual conferences. We have other opportunities such as our pipeline projects in our Student Early Career Board and our Student Early Interest Group. Oop. Before I introduce our moderator, I'd also just like to remind you that this is an interactive session and that we really welcome you to use the chat to chat with each other. So I welcome you to enter your name and where you're dialing in from today, and also chat with our participants, our panelists. They're a great group. If there's a question that they can answer for you one-on-one, put it in the chat and they are welcome to interact with you and answer that. But we'll also be monitoring the chat for questions that we can elevate to bring up to the entire panel. So please make use of that discussion space and get to know each other and our amazing panelists. And without further ado, I would like to introduce Nicole Michaels, who's the principal investigator at the Center for um, Injury Research and Policy at the Abigail Wexner Research Institute at National Children's Hospital. She's also an associate professor in the Department of Pediatrics at the Ohio State University College of Medicine. So I will bring her on and she's going to lead our panel today.
Thanks, Kristen. Welcome, everybody. Good afternoon. Welcome to SAVIR's Injury and Violence Prevention Grand Rounds. The title for today's discussion is Collaborating to Save Lives, Interdisciplinary Pathways to Unintentional Overdose Prevention. Our goal today is really twofold. We want to deepen our understanding of the overdose crisis through multiple disciplinary lenses, and also to spark thinking about how we can break down silos and better connect research, practice, and policy. So thank you all for joining us. Without further ado, I'd like to introduce our exceptional panelists. We have experts from multiple fields, and I invite them to introduce themselves to all of you, tell us who you are, your discipline, where you work, and what you're working on related to overdose prevention. So let's start with Jennifer.
Hi, good afternoon, everybody. Greetings from Munich, where it's very, very cold outside. So I am a medical anthropologist. I have been very successful at never leaving school. So I have a PhD in anthropology, a master's degree in epidemiology, and a master's degree in sociology. And I now teach in a combined sociology anthropology department at North Carolina State University. Prior to entering the tenure track several years ago, God, like 10 years ago, because time is weird. I actually worked at the CDC. I was a contractor there, technically paid by the Atlantic Carolinas HIDA. I was the first scientist working on what is now called the overdose response strategy. I remember when we had a team of 4, and now I think we need to rent out a convention center to fit all the staff in there. So it was fun to be sort of at the beginning of that. I primarily study policy responses to substance use, but I do so from an anthropological lens, which is a way of asking, like, how are we actually conceptualizing and conceiving of the problem, and how does that make certain solutions to the problem that we perceive seem more logical in line with or in spite of scientific evidence that points us one way or another. And I'm also very, very proud to be a direct collaborator with the numerous harm reduction organizations and drug user unions in the US and in Europe.
Welcome. Magda, would you like to go next?
Sure. Hi, everyone. My name is Magdalena Cerda. I'm a professor in the Department of Population Health at NYU Grossman School of Medicine. I'm trained as an epidemiologist. I have a PhD in social epidemiology, which means what I'm really interested in understanding is what are the social drivers of different public health problems. And I really focus on substance use and violence as the two issues of interest. I direct the NYU Center for Opioid Epidemiology and Policy. And as of July 1st, I'll actually be joining the faculty at the Yale School of Public Health. My work really focuses on three things. First, as an epidemiologist, I'm really interested in understanding what are the emerging patterns of overdose. We've done a lot of work tracking the evolution of the overdose crisis across four waves, starting with a surge in overdoses involving prescription opioids to the current time where really it's driven by a combination of illegally manufactured synthetic opioids and stimulants. I also do a lot of work evaluating the impact that current policies and programs have on drug-related harms, particularly public health policies around regulating opiate prescribing, and more recently, work around harm reduction policies. And then finally, I'm really interested in predicting what kinds of interventions jurisdictions need to put in place to achieve their expected outcomes. So I use a lot of computer simulation methods to try to help counties understand how much they would have to invest in evidence-based interventions in order to achieve intended effects in terms of overdose prevention. Really great to be here today.
Wonderful. Welcome. Liz, would you like to introduce yourself next?
Sure. Hi, everyone. I'm Liz Chiarello. I'm an associate professor of sociology at Washington University in St. Louis. I'm a medical sociologist and a sociologist of law. So I do research at the intersection of healthcare and law. I largely focus on two areas, reproductive health and opioids. And I really approach this from an organizational theory perspective. My interest in the overdose crisis has been about how two fields, healthcare and criminal justice, which are just very different fields with different approaches to solving social problems, how they've come together to try to address the same problem, how they use shared surveillance technology in the form of prescription drug monitoring programs, and what that does to workers in both fields of healthcare and criminal justice, and to patients in those fields. So my book, Policing Patients, came out last year, and now I'm working on a new book that's about the criminalization of healthcare.
Liz. David, would you like to go next?
Sure. Hi, I'm Dave Swedler. I'm the senior epidemiologist for behavioral health at the City of Chicago Department of Public Health. A lot of you at SAVIR know me from my work on violence and injury and crashes, but I've also, spent my whole career working on methods and being focused on methods types research. And so flowing into overdose work that I do here, we do overdose violence and mental health here in the behavioral health department. But it just is a natural extension of the type of work that I've been doing throughout my whole career. Um, what do we do here? We like every epidemiologist, we count. And, my epidemiology is about counting and validity and partnering with different organizations to make sure that we're capturing the issue, from all sides and we're seeing all aspects of overdose and substance use. But you will hear me say over and over today during this presentation that, we are just part of a team, not just the department. Our department has a great team, but also our delegate agencies that do on the ground work for us do so much work, so much labor that we can't possibly do. And they have these community connections that we can't possibly forge, as city employees. So, I am the very last person in line as the senior epidemiologist for behavioral health, I'm the last person who sees the data. I'm, the one who just says, is this valid? Is this valid over and over again? But we have such a big team doing so much work, and, it's just good to be here on behalf of the team to describe, the types of work that we do in preventing overdoses and, harm reduction in the city of Chicago.
Thank you. Callan, would you like to introduce yourself?
Good morning, everybody. My name's Callan Thornton. I'm with the Colorado Behavioral Health Administration. By training, I'm a licensed clinical social worker. I have provided direct clinical services over the last 15-ish years, and about 6 years ago came on with the state when I got really fed up and frustrated with some of the systems that the clients I was working with had to navigate. And so my job with the state, I'm called the Maternal Child and Reproductive Health Manager, which means I oversee a portfolio of maternal and child health programs. And probably most pertinent to our conversation today, I also represent my organization on our state's Maternal Mortality Review Committee. And I help to run a public awareness campaign called Tough as a Mother that aims to reduce stigma around maternal substance use disorder, educate local and professional communities, and connect pregnant and parenting moms to support and resources. I always say that I'm a clinician by heart. I love working one-on-one with individuals, and I always think of a policy teacher back in grad school who said you can only do clinical work for so long before you realize how implicated you are in helping to make systems better. And so that's what I'm working on doing now. Thanks for having me here today. Nice to see you all.
Great. Welcome to everyone. So as you can see, we have a great group of panelists today. Thank you all for joining us. So I'd like to start by grounding our conversation in how you understand the problem of unintentional overdose from your different disciplines. So from your perspective, how do you conceptualize unintentional overdose? And what do you see as the core drivers of that issue right now? Dave, would you like to start us off?
Sure. Thank you very much. As an epidemiologist, I always think of, what is the biggest burdens of morbidity and mortality? There's different ways to consider these things. I used to work for health economists, and they're thinking in terms of dollars, costs lost, years of life years lost. But I'm always thinking, where's the morbidity and mortality? And in the city of Chicago, historically, it has been middle-aged and older Black men who are the victims of overdose and unintentional overdose. And so it might not be a population that we think about very often. In Chicago, we have historically had issues with health disparities in terms of health outcomes. And a lot of that is geographically linked as well, the south side and the west side, especially a pocket on the west side of the city where there's a very high amount of substance use and a large amount of disproportionate number of deaths. And so when we think about it here in the city, we're thinking about who is the victims. And as I said, it's not solely, but it's a large burden is held on the, older Black men in the city. And it's a contrast to sometimes what other people think in the area. We recently were granted a visit to the DEA's office downtown to visit their drug testing lab, because we have delegates who do some drug testing as well. And the DEA was very focused on adulterant substances found in club drugs and pills and things like that. And, it was really interesting to see their work, but that's not the burden of morbidity and mortality in Chicago. And so it's very interesting to think about, all these people coming at it from all different angles. But what I am always going for is who is dying the most from this sort of thing. So that's the way, as an epidemiologist, I conceive of the problem and the issue in the city.
Great, thanks so much. So let's hear from someone from a different perspective. Jennifer, do you have any thoughts on this topic?
Yeah, that's super interesting, David. I feel like that's reason like 1437 why the DEA is not worth our tax dollars. Could I ask someone to please share slide number 2 in my deck? So I think that this is all what David has shared, and what this group has talked about previously is very correct. I find it really helpful to focus down on um, uh, sort of a more biological conception of overdose. Because, as I said, as an anthropologist, I'm really concerned not just with the sort of empirical realities of what's happening, but also how people are converting those realities into narrative. Um, Good political scientists and anthropologists and sociologists worth their weight will tell you that, despite all of the love affair that this whole panel has with data, human beings don't make decisions based on data. They make decisions based on stories, right? And so, how do we make stories out of all this? Oftentimes, I hear engaged, interested, intelligent members of the public talking about overdose, like something that just naturally happens following exposure to illicit drugs. And that's really not the case. It's not the case the same way that it's not like a natural consequence of sexual intercourse to contract an STD, the same way it's not a natural consequence to experience a gunshot wound by accident if you have a gun in your home and are storing it properly. There are factors that need to collide in order for that to happen. So rather than thinking of overdose as a consequence of exposure to substances, I think it's much more helpful for us to think about overdose as the opposite of proper dosing, right? Obviously, abstinence will prevent you from having an overdose, but if you are exposed to drugs, there are ways to do it therapeutically and in ways that minimize that risk, right? So the way that this is often thought about clinically is through what's called a therapeutic window. So, my friend downstairs has a migraine today. She took some medication, and if she's below the therapeutic window, it's not going to take the edge off of that headache. She's not taken enough to get that therapeutic dose. If she goes above the therapeutic window, she's going to start experiencing side effects, depending on what she decided to take, either disruptive and uncomfortable or potentially dangerous side effects of the medication because she's experiencing the symptoms of toxicity. But in that sweet spot in the middle is where we have a nice balance between sort of risk and therapeutic effect. So we know there are things that can shape where that therapeutic window is, but really we hit it by making sure that our dose and our tolerance match. Now, different medications have different therapeutic windows, and there's lots of different factors that go into it, but we want our tolerance for the drug and the dose of the drug to match. Could we advance a slide, please? So we know things that shape tolerance and affect tolerance, and this is something that even lay members of the public are starting to understand more and more. It's sort of like left academia and the expert spaces, and is now widely understood that periods of abstinence-based treatment, detoxification without medication continuation, periods of incarceration, even periods of voluntary, willful abstinence, like if someone just decides on their own to stop using for a while, returning to use can be really risky because your tolerance has dropped and you don't quite know where it is, so you don't quite know how to dose yourself properly. Best case scenario, you make a lucky guess, but you could fall below that therapeutic window or often above it, even if you're trying to be very cautious, right? So all of these things, incarceration, abstinence-based treatment, detoxification without medication, we know affects tolerance and increases the risk of overdose. But also fluctuations in dose or the inability to dose properly drives overdose. And we have a growing body of evidence. At this point, I think it's fair to say it's pretty irrefutable, although the social and political conversations about this are harder to have. But disrupting the drug supply, right? People losing access to their primary supplier, people losing access to supply that they're familiar with, can all lead to unfamiliar dose. A lot of folks, because they don't have access to different information, seem to believe that, cocaine is cocaine is cocaine, heroin is heroin is heroin, fentanyl from one person is the same as fentanyl from another person. Spend 10 minutes in any harm reduction program in your city, and you know that's not the case. I've been doing point of service drug checking in my hometown of Durham, North Carolina, and every bag that people bring in is wildly different, right? So things that we do that are going to really mess with people's tolerance or mess with their ability to find a product that they are confident in and familiar with is going to drive up overdose. Obviously, across demographics, these things affect people differently. Like David was saying, that's extremely important to pay attention to. But these are those sort of two root causes that really help us understand what creates the opportunity for overdose in every situation and why.
That was really interesting already to kind of see the different perspectives and how they're connected and also how they're different. So let's connect kind of everyone's work to the broader overdose prevention ecosystem. So how does your work connect with national priorities or broader public health strategies around overdose? And I'm also curious, where do you see the strongest disconnect between research and policy and practice within this space? Magdalena, do you want to start us off?
Sure. So, as an epidemiologist, my priority, really what drives me, is using science to inform policy and practice to, among other things, address the overdose crisis. So, because of that, a lot of my research really does focus on evaluating current policy and practice that is implemented to address overdose. In prior years, I did a lot of work evaluating the impact that policies enacted to regulate opioid prescribing had on chronic pain, opioid use, and opioid overdose. And that was really because there was a lot of attention paid to, for example, the adoption of mandated query prescription drug monitoring programs or pain management clinic laws or limits on prescriptions, on opioid prescriptions. And so actually that work found that although regulating opioid prescribing did lead to a decline in inappropriate prescribing and a decline in prescription opioid overdoses, it did also have some unintended consequences in terms of contributing to the rise in overdoses involving heroin and illegally manufactured synthetics. At the current time, when we've seen the nature of the overdose epidemic really shifting towards illegally manufactured opioids, attention in terms of policy and practice, particularly until I would say the last year, has shifted more towards the potential role that harm reduction can play. And so harm reduction, thinking about services that meet people where they are and that try to reduce the harmful consequences associated with drug use. And so because of that, my work has really shifted lately towards evaluating the impact that harm reduction policies and harm reduction programs have on overdoses. I'm doing some work now. We're collecting data on what are harm reduction laws like in almost 500 municipalities across the country. We actually have very little data on what's going on with harm reduction policies at the local level. And so we're collecting that data and we're going to see what impact do those laws have in conjunction with state laws on drug-related harms. I'm also doing the first study of publicly recognized overdose prevention centers in New York City and Rhode Island. Overdose prevention centers are places where people can go to be safely monitored following drug use and be connected to services to prevent overdose and to prevent other harms. In my work, I've really been struck sometimes by the disconnect between what we know works, what research says works, and what is sometimes public perception and attention in policy. I'll give you one example. So we've seen in the past few years a shift from injection drug use to smoking. And part of that shift has really been a harm reduction strategy. That is that in smoking, you're at a lower risk of overdose than with injection. However, the policies have actually not followed that data. And what do I mean by that? I mean that whereas I would say more than half of municipalities across the country allow for the distribution of syringes, distribution and possession of syringes, clean syringes, a small minority of municipalities actually allow for the distribution and possession of safe smoking equipment. So that's a clear example where we know there's a transition towards smoking, yet it's actually not possible to actually legally acquire equipment that one needs to smoke safely. So I'm hoping that we can establish greater communication between research and policymakers to be able to use evidence to drive policy.
Great. That's a really interesting point about how we treat different harm reduction strategies, kind of depending on what else is happening, in the administration or policy wise. Callan, do you have some thoughts?
Yeah, I'd love to jump in here and first just say, I think harm reduction and treatment and recovery services are irrefutably so important. And I also come from a bit of a different lens. I want to speak specifically about where I see a huge disconnect in terms of policy and practice and really where we invest federal and state dollars. So I see there being a huge issue in getting upstream of the overdose problem. My training is really at the intersection of trauma, substance use, and mental health. And I work a lot with infant and early childhood mental health. So we talk a lot about something called ACEs, which you all might be familiar with, which stands for Adverse Childhood Experiences. And we have really good data that says the more ACEs or traumatic events that a young person experiences in their life, the more likely they are to misuse opioids and the more likely they are to have an overdose event in their lifetime. So I think the stat is with 5 or more ACEs, folks are 15 times more likely to report opioid misuse than those who experience no ACEs. And this was a study that was published in the Journal of Pediatrics talking about students. And so one of the things I think a lot about is that most of our federal SAMHSA dollars, our substance use prevention, treatment, and response grant dollars, I think around 70% of that goes into treatment and harm reduction, which again is so important. But a fraction of those dollars goes really into strengthening family systems, strengthening communities, doing that primary prevention work to try to prevent young people from having traumatic events early in their lives. So that's an area that I'm really interested in, of trying to move money and efforts and have our state really follow what the data says in terms of where to invest those dollars so that we're in a really different place 20 years down the road than we are right now.
Great point. Jennifer, I see your hand up.
Yeah, thank you. I wanted to very briefly expand on something that Magdalena said, and that is, there was a pretty boisterous political conversation about distributing smoking equipment nationally a couple of years ago. I know that there are some individuals who would prefer to see harm reduction and the distribution of supplies not happen generally. I would say that that is a moral claim about policing people's bodies, not an evidence-based public health claim. But there are also those who have come around to the reasonable idea that the distribution of injection equipment is a public health good, but cannot comprehend the public health benefits of distributing smoking equipment. I don't think we need, personally, I don't think we need a public health justification to distribute smoking equipment. I think it's just a nice thing to do because people want it. And the more services that are offered and programs, the more likely people are to show up and run into the food and run into the clothes and run into the laundry and run into the social worker and run into the, HIV counselor and get back on treatment and so on and so forth. Like it's just a form of care that we do. But I want to highlight very, very explicitly the fact that despite everyone smokes, right? Everyone smokes drugs, people of all different backgrounds. But as a society, hat tip to the Nixon administration as well, but everything from there on, we so strongly associate the smoking of illicit substances with the Black population in this country that we can't overlook and probably can never overestimate the degree to which anti-Black racism is really driving a lot of the discomfort with distributing smoking equipment, even if it's in one of the predominantly white rural counties of Western North Carolina where I sometimes work, right? So I think that's a very, very important thing to keep in mind as we're discussing sort of public and political comfort and emotional responses to these different strategies.
Wow, that's a really great point. I appreciate you bringing that up. So because you're all kind of from different backgrounds, different disciplines, each discipline has kind of their own framework that they like to use to talk about these issues. So from your perspective, what frameworks or theories kind of help you make sense of this, multifaceted problem that we're talking about today. Liz, do you want to go first?
Sure, I'll start us off. So I want to make a shameless plug for the value of the social sciences and the humanities. And doing so, I want to pull together one of the things that Jen said earlier, one of the things that Callan said earlier. So Jen mentioned the value of stories, and Callan talked about getting upstream of this particular crisis and really thinking about capital P prevention and what it looks like. And what that makes me think about is the author Chimamanda Ngozi Adichie, who has this fabulous TED talk called The Danger of a Single Story. And what she says is that the problem with a single story is not so much that it's wrong as that it's incomplete. And when we tell ourselves incomplete stories, we end up with incomplete solutions. And so, what I think social sciences, sociology specifically, and the humanities do best is put social problems in a historical context and then also use theory as connective tissue so that we can understand social problems in relation to each other. And if we don't do that, everything seems brand new, right? So Jen talked about how smoking is associated with the Black population and how that affects the way we understand smoking. Well, it was also associated with Chinese immigrants at the turn of the century when they came here to build the railroads. And so there's a through line over the last 100 years. And what I think the problem of the single story when it comes to the current opioid crisis um, is that we think it happened in the last 20 years, and we think it happened because of a uniquely bad set of actors, the Sackler family and Purdue Pharma. And like there are tons of books about it. There are movies, there are TV series. I mean, we know that the Sacklers are the baddest of baddies. And if we tell ourselves that story again and again, we miss that the Sacklers look like Enron, and they look like the banks, and we can't see that through line. And we miss that we've spent the last 100 years toggling between this question of whether drug use is a problem of sickness or a problem of badness. And that the fact that we have incompletely medicalized drug use has left us in a position where we're shocked every time a new crisis comes along. And first we think, oh no, this is sickness. And then we say, oh no, it's actually badness, depending on who's associated with it. And so the theories that I think are really helpful from sociology are theories about medicalization and criminalization and the way that social problems move between them, but also about issues of stigma and deservingness. So who are we making sense of? Whose behavior are we trying to understand? And the other piece that I'll say is we also have separated people in chronic pain and people with substance use disorders or people who use drugs more generally. And those two groups have been pitted against each other in this fight over opioids. And if we take a broader perspective and think about, the drivers of chronic pain and the drivers of problematic drug use, we end up with a very different story that then leads to different solutions. But we can't keep hammering in on this single story. And that's what I think theory can help us do.
That's great. Yeah, this is, there's so much of this is tied up in, stigma and criminalization and social determinants. Other thoughts before we move on to talking about different approaches to addressing this issue? Okay. So let's shift our discussion to think about, some of the solutions. Like how do we address such a massive problem? So what interventions or strategies from your field have been shown to have promise? And kind of related to that, how do you balance these evidence-based approaches with the realities of, we work in communities with real people, we have political constraints, we have limited resources, especially these days. So, how do you kind of balance these things? Dave, do you want to start us off?
Sure. Kristen, could you please go to my first slide that I had there? So as I said, we do a lot of work as a group. And this slide was put together by one of my staff, and so it looks very pretty. And these are our CDC-funded Overdose to Action grant projects that we have going on. Right now, we've got medication-assisted treatment, the MAR Now program. We've got NADP, Narcotics Arrest Diversion Program, where people are at the police station are being diverted into non-arrest situations. We have drug checking program, opioid response encampment outreach, re-entry care coordination, and also then learning library there on the bottom. So this is just our OD2A grant. And if you go to the next slide, you'll see a less pretty slide, which I made, which has our non-OD2A projects. This includes some OD2A, some CDC funding, but also opioid master settlement funds and city-funded programs. We're looking at linkage to care. We're working on that. We're starting up this year an ED Bridge. Some of you may have heard of the California Bridge program. But the ED Bridge, we're putting this together to have 7 or 8 hospitals in the city that are going to be doing ED Bridge style work. We are starting up a recovery services / recovery residence location. We do door knocking to distribute information. When we're talking about political limitations in Chicago, we will do it all. We will try basically anything. And so for those of you who are looking for a great place to live and work, I'm telling you, Chicago is where it's at for fellow forward-thinking opioid injury and violence prevention people. But we will try anything, and our community members make this work happen. And we are just a Department of Public Health, but everyone who's working with us is out there in the community doing this work, and they're our hands. They are on the ground for us, putting all this into action. So we will try anything. We have got all these evidence-based programs that we use, and we are just throwing everything we can to stop our humongous bout of morbidity and mortality that is the overdose crisis in Chicago.
Thanks, Dave. If you could make it just a tiny bit warmer in Chicago, I would be
It was
sold.
60 degrees yesterday, and it's in the 50s now, so that's your last excuse.
I'm there. It's awesome. Thanks. Let's see. I know we have some other folks who have some things to contribute here. Magdalena, do you want to talk about some of your what you've seen?
Sure. This is really so interesting, Dave. Thanks so much for sharing what's going on in Chicago. Chicago's always a leader in the field. I think taking a broader perspective in terms of what I've seen in the literature, I would say the way forward is to really take a multi-level approach to this issue. So to invest in primary prevention, to invest in treatment, in harm reduction and recovery. So just starting out with primary prevention, as I think Kellen raised at the beginning, I also agree there's not enough attention paid to that, right? To trying to understand how can we prevent kids from starting to use drugs early? How can we prevent people from starting to engage in drug misuse? And so there's actually evidence suggesting that really investment in early intervention programs and horizontal prevention programs in families and in schools can have cross-cutting benefits. So, for example, something like the home visiting program, like the Nurse Family Partnership, that works together with families to support young mothers, actually has had long-term effects in terms of adverse childhood events, behavioral problems, and substance use and mental health. Horizontal life skills programs that are particularly focused within the school setting and work with kids to basically develop skills to manage feelings, to manage conflict. Those also seem to have cross-cutting benefits in terms of substance use and mental health. So it would really put a plug in for the value of early intervention in homes and in schools. Also, I would put in a plug in for broader policies, investment in social and economic policies that strengthen financial security and buffer against job loss and housing loss, particularly among low-income and working-class communities. Like, for example, expansion of unemployment benefits, income assistance and minimum wage, Medicaid expansion. There have been studies that have shown that all of these have positive effects in terms of preventing drug use and preventing overdose. At a secondary level, investment in treatment, and so investment in evidence-based treatment, medication for opioid use disorder, so basically all the programs that lower thresholds to access buprenorphine, methadone, naltrexone. So really expanding the types of providers and settings that can provide medication for opioid use disorder in emergency departments, in federally qualified health centers, in pharmacies. And really there, really investing in continuity in treatment during and after incarceration should be a big priority. Third is harm reduction. So we've talked a lot about that. I think there's a lot of evidence showing that low threshold access to harm reduction services, particularly those with wraparound services, so that include connection to transportation, to clothing, to food, to housing, are particularly promising. And that can include both community-based harm reduction services, but it can also include more than that, right? So naloxone saturation in settings where there's significant overdose vulnerability, like in permanent supportive housing or in carceral settings, as well as mail order harm reduction supplies for people who live in areas that are isolated and then won't be able to access harm reduction settings. So I think really paying attention to this kind of multi-level approach is going to be the most promising in terms of moving us forward.
Awesome. Thank you. Callan, can you tell us more about your Tough as a Mother program?
Sure, I'd love to. And I have a slide that shows you some of the visuals of Tough as a Mother. So Tough as a Mother is an example of a public awareness and stigma reduction campaign. And it's been wildly successful in Colorado, so much so that we've had other states approach us and ask to license it in their states, which we are in the process right now of licensing with 4 other states. But it's really in response to, I mentioned earlier that I sit on our state's maternal mortality review committee. And if you didn't already know this, unintentional overdose and suicide are 2 of the leading causes of preventable maternal mortality. And as one of the panelists said earlier, that those time periods where somebody has changes in tolerance or periods of abstinence, so pregnancy is often one of those time periods, puts somebody at very great risk of overdose. So in Colorado, the data shows that postpartum women who have overdoses and die from them, it's happening so of those who are pregnant or postpartum, 90% of the folks who die are in the postpartum time period. So it's a very high risk time period. So this campaign sort of came out of wanting to reach out to both pregnant and parenting moms and really combat some of the stigma that they're facing as they navigate the healthcare system and becoming a parent. I think it's really important to call out the stigma here because pregnant individuals are, maybe one of the most stigmatized groups when it comes to using substances, whether there's a substance use disorder or not in play. And the campaign really reaches out to moms to say, hey, we're not here to make a judgment about whether you should or should not be using substances. And we're substance agnostic. It doesn't matter if somebody is using cannabis or tobacco or heroin or methamphetamine. We're really just saying if you are uncomfortable with your use or you're experiencing negative consequences related to your use, we're here to help you stop. We're here to help you get support. We're here to help connect you to harm reduction, peer recovery coaches. So we have a map that you can see here on the screen where folks can go and look up their nearest treatment center that has specialized women's services and also offer childcare and help to link to pediatric and prenatal care. I'll also say, I think one of the most beautiful parts of the campaign, what research really says is one of the most effective ways to reach people and get through stigma is for folks to hear from other folks who have the same lived experience. So within the campaign, we have kind of a micro campaign that's called Recovering Out Loud. And the tagline is Recovering Out Loud so that other moms don't have to struggle in silence. And we have really brave moms all across Colorado who have filmed their stories and have shared those stories on behalf of other moms who may still be struggling. And Dominique, if you go onto the website and you listen to Dominique's story, she says people can and do recover every day. And she just repeats that a lot. And as I've talked to moms, they have told me how meaningful it is when they're having a hard time and when they're having cravings, feeling lonely, that they go onto the website and they listen to these stories of other moms just to remind them that it's possible and people can and do recover every single day. We have a really vibrant social media community. We have a free virtual online support group that's led by peer recovery coaches every week. We also have a really neat new thing on TikTok where we have an addiction medicine specialist in Colorado who is just such a unicorn. We all wish we could clone her, but there's these little 60-second clips where she's helping to combat some of the most common misinformation about pregnancy and substance use and risk in the postpartum period. So I encourage you to check it out.
Awesome. I love everything about that. Thank you for sharing. Jennifer, I see your hand up.
Yeah, so channeling the wisdom of Chimamanda Ngozi Adichie, I'm going to sort of say the same thing that other folks have said, but in a slightly different way. Can I please ask for slide number 4 in my deck to go up? I think so. I'm going to talk about some of the evidence-based strategies that currently exist, but I want to also lift up and endorse the next one, please. Yeah, perfect. I want to lift up and endorse some things that my colleagues have been saying that all the things that we know work can only work in a world where we are good to each other, right? Where we have love for one another, where we have empathy for one another. This is really, really important to me, not just as a scholar and a researcher, but as a person. Before I was an anthropologist, I was a youth minister for 7 years. Before I was a youth minister, I was a young person watching people around me die and being very confused as to how the adults around me were reacting to these things. And so just holding space to be kind is hugely important. But what I want to do is sort of reframe what was just said in this way. So this is a document that was put together in 2018. I've joked that this is the most peer-reviewed thing I have ever read, and yet a high schooler found a typo in the title literally yesterday, first person in 8 years. So Annabelle in Chicago, you amaze me. Go consider a career in government. But we did this sweeping review of evidence, and we're like, these are the things that effectively interrupt the overdose process and are evidence-based overdose prevention strategies, right? So what made it into the book was medications for opioid use disorder with agonists, so buprenorphine and methadone, not naltrexone, eliminating prior authorization through insurance companies for those medications, having those medications in criminal justice settings, having access to those medications and initiating them in the ED, academic detailing for healthcare professionals, targeted naloxone distribution. That means putting it in the hands of people who use drugs because they are most likely to be present at the scene of an overdose. Naloxone access in treatment centers and criminal justice settings, Good SAM laws, syringe service programs, and screening for fentanyl and routine toxicology. If I could go back now and update this document, which in the current environment we cannot do, if you could advance a slide, please, I would reorganize them this way and make some minor edits. So I would add drug checking to fentanyl test screening and routine clinical toxicology back in 2017 when we were doing the first draft of this. The first major paper on fentanyl test strips hadn't been out yet. We all kind of understood that this is a logical and highly promising intervention, but we didn't have the data yet. We absolutely do now. And as the primary author of this document, I am extremely comfortable saying that drug checking, community-based drug checking, 100% more than exceeds the barrier to entry for a document like this, right? The other thing that we should add is overdose prevention centers. If you do look up this document on the CDC website, you'll find a little preamble in the front that mentions that there's other strategies that have been implemented outside the United States that we cannot advocate for in this document because it is contrary with federal law. That's overdose prevention centers. The only reason why it's not in this document is because a federal agency wasn't allowed to advocate for that strategy at that time. But I also want to point out a better way to organize this, right? So essentially, we have five major interventions that are evidence-based: medications for opioid, agonist medications for opioid use disorder, naloxone distribution that is targeted, syringe service programs, not only because they provide access to all of these, but we have data that tells us that simply participating in this open, accepting, empathetic, safe environment propels people into recovery trajectories. Drug checking and overdose prevention centers, everything else in that list just breaks down a barrier to one of those 5 major pillars of overdose prevention, right? So when I do interviews or talk to students or talk to journalists and they ask what should we be doing? What sort of things should we be trying as a community to end overdose? I'm like, hey, great news. we know what to do. We've known what to do for like 10 years, right? Like these solutions have been out there. We just need to fully invest in them. If you could advance the slide one more time, please. And this is why they work, right? So each of these five interventions has three specific things in common. One is that they directly address the underlying problem of either unpredictability of dose or of tolerance. Right? So medications keep your tolerance up. Naloxone is an emergency response for when you don't have that match between dose and tolerance, right? That's precisely the toxicity that it interrupts. Drug checking helps you understand your tolerance. SSPs provide access to all of these things. OPCs provide even more robust access to all of these things. The second thing they have in common is that these are developed by people who use drugs. I gave this might not be 508 compliant, excuse me, but I gave the check under MOUD a slightly lighter green because it's really safe supply that has an intervention that has been innovated by people who use drugs, but methadone access has been sort of brought into the big house of safe supply access by drug user unions and organizers. So, but naloxone distribution pioneered and done sort of underground for a long time by people who use drugs before it was widely accepted and legalized. Drug checking pioneered by people who use drugs and widely done underground before it was accepted and legalized. Syringe access pioneered by people who use drugs and widely practiced underground before it was legalized and accepted. Overdose prevention centers happening in a neighborhood near you right now, no matter where you are in the United States, right? So it's people who understand these risks and these problems the most intimately who are consistently developing the most effective interventions. And finally, they're all evidence-based. Like research has repeatedly and consistently shown that these are effective attributes. So what I often encourage people to do is like, if you want to innovate about how you can bring these five pillars more fully into your community, innovate about where this can be integrated into existing services, integrate about what partners you can bring together to do it more robustly. But we have so many communities, especially with the opioid settlement money coming down the pipeline, who are just dying to wing it and dying to reinvent the wheel and come up with something new. When in reality, like this is what we know. This is what works. This is what works. Again, I want to echo and lift up what my colleagues are saying that we have to have stigma-free environments. We have to be able to be kind to each other. We have to be able to provide appropriate care for, neonatal opioid withdrawal syndrome and provide appropriate resources to parents and deal with their very real and very grounded fear of child and family services involvement and all of these things. But all of that to me is this whole like, can we be good to one another? And then while being good to one another, make sure that folks are just tripping over these services, that you have to like beat them away to not have access to rapid MOUD, rapid naloxone, drug checking, all these sorts of things. This is what works. This has been what works for as long as I've been in this line of work.
Great. Thank you, Jennifer.
Yeah.
Just going to pause for just a second and point out that we do have some folks putting resources in the chat. I know Liz put some things there and also Callan, so be sure to check those out as you're listening or afterward. And also, kind of start gathering your questions that you might have for our speakers. I have a few more questions that I would like to ask them, but then we're going to open it up to the floor. So start thinking about those. You can put your questions in the little Q&A box down there at the bottom. So we were talking a lot about like successes, innovation, what's working. I'd like to kind of look at the other side now. So, we all kind of go into this with good intentions, with big ideas, but not everything works out, the way that we intend. And sometimes, we mean well, but can actually end up doing things that can cause more harm. So let's talk a little about like what strategies or policies or programs have failed or maybe produced unintended results or things that just have taught you personally important lessons in this field. Liz, do you want to start us off?
Will, I'm going to talk about two cautionary tales. So one of them is, I think we can all agree that letting corporations profit off of addiction for decades and then trying to claw that money back through lawsuits years later, after a lot of lives have been lost and a lot of people have been harmed, is just terrible public health policy. But it seems like that's the thing we keep tripping ourselves into, right? It happened with tobacco, it happened with opioids, it's about to happen with gambling. One of the things that we know is that addiction is extremely profitable. And so thinking about what regulations need to look like ahead of time, really taking seriously that an ounce of prevention is worth a pound of cure, I think is really essential because we're just in this place where we're trying to play catch up, and we keep ignoring what works. The other cautionary tale that I want to talk about is technology. We live in the digital age. Many of us have seen AI incorporated into all kinds of different elements of our work. Certainly at my university, we're asking these questions about the role of AI. Um, but my research focuses on the prescription drug monitoring program, which it tracks all of the controlled substances in a state, and feeds that information back to healthcare providers who can use it to monitor patients. But it also gives that information to law enforcement who can use that information to monitor both patients and providers. And I think that at a time when the prescription side of this overdose crisis was really ramping up, prescription drug monitoring programs maybe seemed like a great idea. But what I show in my research is that PDMPs help to blur the boundaries between healthcare and criminal justice and push healthcare providers to act more like cops in ways that undermine their commitment to their profession and to patients. And so I think we have to be really careful before we adopt bright, shiny new technologies. Tech has decided they're going to move fast and break things, but also that they can solve all of the world's problems. You'll notice that the things that Jen just spelled out about things that really work in this space do not require a new AI tool. They don't require some new tech innovation. They require a lot of humanity. And so that's what I would say is let's be really careful about technology. And also, let's not keep doing the same game of letting companies do whatever they want and then trying to hold them accountable later because we just never do.
Great point. Magdalena, do you have thoughts?
Yeah, I would fully agree with what was just said. I mean, to put it in other words, I think a really important priority for this country is the need, and in terms of thinking about things from a public health perspective, we need to regulate consumer products. We need to regulate them well in order to protect public health. That was the case with opioids. It's now also the case with cannabis, right? We're seeing with cannabis, it's being legalized widely across the country, often without a regard to evidence in terms of what works to prevent unintended consequences, what we've learned from tobacco, what we've learned from alcohol. The same thing happened with prescription opioids. We keep doing this again and again when we allow corporations, we allow industry to determine what is and is not regulated, and that keeps having public health consequences. So I think using evidence to regulate consumer products and to think about their public health consequences is something that's really important. The other issue, and related to the comment about the prescription drug monitoring programs, is I think a larger issue here is that we often our approach to addressing a problem with drugs is to say, well, it's a supply-driven issue, right? And so what we're going to do is regulate the supply, and if we regulate the supply, then everything will be okay. And so, like, that's what happened with prescription opioids, where we saw the rise in opiate prescribing and we saw the concomitant rise in overdoses involving prescription opioids. And so we said, how are we going to solve it? We're going to implement a number of laws and policies to regulate how opioids are prescribed. So that meant prescription drug monitoring programs. It meant laws regulating pain clinics. It meant limits on the quantity and length of opiate prescriptions. And that was really widely adopted across states. But what happened? What happened is there was a lot of attention paid to that and not enough attention paid to, well, why are people using drugs, right? What are their sources of demand? And why are people using drugs in circumstances where they may be more likely to overdose? And so with that lack of investment in interventions and in policies that address demand, And with just cutting off the supply, what you see is unintended consequences. So we saw it with prescription opioid supply became less available, more expensive. People were still dependent on opioids. So what happened? They shifted to the illegal drug market. They shifted first to heroin, which dropped in price and increased in purity at the same time that prescription opioids became less available. And then they shifted to other illegal opioids. And so and so we saw a continued rise in overdoses, right? So we saw that unintended consequence. We're seeing, I think, the same thing now, where we're seeing a substantial decline in overdoses. And there's this idea that it's all because fentanyl is less prevalent, less lethal in the drug supply, and that's why we are where we are. I think that's an open question, and I also do really worry about this conclusion that it's all about the supply. Is that going to lead us to, again, have unintended consequences if we don't keep investing in a lot of these other programs and policies that address demand, like primary prevention, like treatment, and harm reduction?
Great points. Jennifer, I know you put some things in the chat. Is there anything else you wanted to add?
We're in the cautionary tale
Yep.
question.
Mhm.
Yeah, so super briefly, if we could advance one slide for me, please. I mean, there's a few things that are really, really popular. I mean, I could talk all day about how frustrating it is to watch people reinvent the wheel. I won't. But I have a couple examples of things that are just super harmful. One that I've been studying a lot lately is death by distribution or drug-induced homicide laws. Ostensibly, most prosecutors that we survey, and we've surveyed a lot, think that these laws have no public health impact. Those that do believe that charging people for a homicide or a crime equivalent to homicide for being involved in an overdose death has the potential to deter fentanyl use, deter fentanyl distribution, or reduce overdose in their communities. And a very substantial body of evidence tells us that the opposite is true, because these essentially function to disrupt the supply, and they directly undermine 911 Good Sam laws. We have repeated, consistent findings from 4 different regions of the United States that tell us this. If you could advance my slide, please. Thank you. This is just a quick breakdown of 3 different studies. The black bar is no one going to treatment at all. We have 3 studies, the burgundy, the blue, and the gray, that tell us that opioid agonist treatment with methadone and buprenorphine, depending on the population you look at, dramatically reduces the risk of death. We're talking between 40 and 60%. 40 and 60% reductions in overdose among populations receiving that treatment. There's a new study out of Connecticut, actually, that shows that any treatment received that doesn't involve those medications or opioid use disorder actually increases the likelihood of overdose, almost 80%. Right. So it's not just that these are things that work, it's other things are proactively harmful, and encouraging people, or oftentimes in my city, people are court ordered to treatment centers that deny access, contrary to the strictures of the Americans with Disabilities Act, deny access to these medications. If someone chooses that for themselves, bodily autonomy reigns supreme, and people have a right to make that choice for themselves, and they should be absolutely supported in making that choice. But that support has to include safety planning, overdose prevention planning, understanding what's going to happen when their tolerance goes down. It involves a lot of support. And the next slide, please. And we also know that we have, again, repeated findings that just basic law enforcement of criminal drug policies in the United States increases overdose. So this includes arrest of people for drug crimes and the seizures of drug supply, whether it's a personal supply or a larger supply of drugs. This was a study that we did in Indiana. It's been repeated in San Francisco. The Washington-Baltimore HIDA is publishing papers that tell us that this is true in their district as well, that their major drug busts consistently predict spikes in overdose in the following community. I know this table is messy, but we found that when opioids are seized, there's a 4.7 times increase in non-fatal overdose and a 2.2 times increase in fatal overdose. So a doubling of fatal overdose in the area immediately surrounding where that seizure happened. Right. So again, it's disrupting that dose. And I just want to be, I think it's time that we be super, super clear with ourselves that things that make sense in common logic and that so many political leaders, local leaders, community leaders are telling us will work of like, we just need to get the drugs off the street. We just need to sort of like enhance this enforcement is actually driving the overdose that we see is responsible for a huge amount of excess overdose. And I would conclude by saying, I find it personally very disturbing that we have a growing body of evidence, a very robust and um, very chilling body of evidence that ordinary police interactions with people who use drugs drive excess overdose. And then when fatal overdose does happen, we have prosecutors who are lining up to prosecute a community member for the death that police action most directly caused. And that causes me great trouble. Law enforcement is often very disinclined to have a conversation about that, and yet again and again and again and again we find that's the case.
Great point. Thank you for sharing your perspective.
Yeah.
So one of the major goals of this session is really just to help people think about how we can connect across different disciplines. We have a lot of silos, even within my own institution. You don't always know what other folks are working on. It's sometimes hard to find the time to connect or to know who to connect with. So, what kind of silos have you seen in your work in this field? And thinking about how those might limit our progress, and also how we might overcome those. Dave, what have you seen in your work?
So one of the silos that we've been, we think about, and it was just mentioned, was, limitations of working with law enforcement, especially when they're cracking down on things. But one of our partners who's actually been really helpful with us is the Cook County Sheriff's Office. So Cook County is a county that entirely surrounds Chicago. It's 5 million people live in the county, to half of that population lives in the city. And so the sheriff is responsible for the jail system in the whole of the county. And if you've ever heard our sheriff speak, he says he runs the largest mental health clinic in the world, which is probably accurate, but not entirely. But there's a lot of substance use issues that are being dealt with completely or incompletely in the Cook County Sheriff's Office through their different issues that they have to deal with. And it turns out of late, they have been one of our most helpful partners in terms of getting people linked as they're exiting the facilities. Now, I'm, as an epidemiologist, I'm not the program expert to tell you about the details of this program, exactly what they're doing. I've only been with the department for a year, so I can't fill you in on all the details of that. But Cook County Sheriff's Office has been one that has been very helpful to us of late. And, our program staff has been speaking very highly of the Cook County Sheriff's Office for what they've been doing for that. Other institutions that really help us, UIC, University of Illinois at Chicago, has a whole bunch of organizations, both their public health and medicine and different departments, are working with us, giving us their expertise, doing street medicine, doing encampment outreach, doing drug checking. These are organizations with like the theory experience, but also the practice experience getting out there with them. And so we really appreciate UIC, School of Public Health, and their School of Medicine and their hospital for what they do with us. So those are two, the Cook County Sheriff's Office and the City of Chicago. But as you saw in that really pretty looking slide that my coworker made, there's a lot of organizations that work with us. But right now, I would say that Cook County Sheriff's Office is a kind of surprise, really good partner for us.
Yeah, that's great. We, with one of our fentanyl test strip studies, we've been trying to work in the courts, and it's here in Ohio. It's very hit or miss, right? We have some judges that are all on board, very enthusiastic, even some of our judges in rural counties. But then you run into other folks who are like, we are abstinence only, like we don't support that kind of thing. And so it's really been eye-opening, to say the least. So thank you. Let's see. Callan, do you have some thoughts to share on this?
Sure, I'd love to. So again, my vantage point that I'm coming from is really focused on maternal and early childhood health. And I'll give you some examples of silos we've seen in that field. First, I want to just say that I think we've done a really great job over the last couple of years of reducing silos. Colorado has seen a 60% decrease in pregnancy-associated overdose deaths between 2022 and 2023. So we're looking hard right now of like, what have we been doing that has really helped to drive this reduction in overdoses? An example of that, historically, there's a huge disconnect between the healthcare system and the behavioral healthcare system, and even more so when you're talking specifically about substance use disorder treatment, behavioral health system. And one of the things that has often happened, so let's say I'm a pregnant person with a substance use disorder, I get some prenatal care. My prenatal care provider doesn't share an electronic health record with the labor and delivery hospital where I go to deliver the baby, and the labor and delivery hospital doesn't share any records with the pediatrician or any community-based organizations that I may be receiving support from afterwards. So we've been working really hard to try to build connective tissue between prenatal care providers, family medicine providers, our labor and delivery units in Colorado, and community-based organizations, and having learning collaboratives where all of those entities come together and work on learning evidence-based screening, brief intervention, and referral to treatment practices. We've had a really hard time historically getting OBGYNs to see themselves as invaluable in somebody's substance use disorder treatment. So even though overdose is a leading cause of death among pregnant and postpartum people, a lot of OBs have been really hesitant to prescribe MOUD or even to use evidence-based screenings and talk about substance use. So we've been really working on helping build a broader team and trying to change the way that professionals see themselves in terms of being implicated in somebody's whole person care. And that's actually been going really well in terms of, some of the panelists said this earlier, but targeted naloxone distribution in labor and delivery units, initiating MOUD in labor and delivery units instead of having policies that say, hey, we'll refer you out and hopefully you'll show up to your appointment next week. And then one other piece with the law enforcement thing within the healthcare system, many labor and delivery units have policies that say, you know, if there's any drug use during pregnancy or suspected drug use during pregnancy, it's an automatic finding of child abuse and neglect and opening a case. In Colorado, our child welfare data showed that we had a disproportionate amount of children of color in the child welfare system related to some of these non-evidence-based predatory toxicology testing policies. So we've also done a lot of work on trying to bring together the child welfare system, infant and early childhood mental health professionals, labor and delivery, NICU, hospital healthcare systems, and social workers, and advocacy organizations in the state to review policies and really work on implementing evidence-based policies in labor and delivery units to both decrease overdose and harm to family systems, and also to try to keep families together and keep kids out of the child welfare system.
Great, thank you. Liz, what kind of silos have you encountered in your work, or what advice might you have for folks who, you know, are running into these challenges?
Yeah, there are three silos that I'd really like to highlight. So, one of them I mentioned earlier, which is the disconnect between people who research and advocate for people who are in chronic pain and people who research and advocate for people who use drugs. And I think the challenge is that these two groups not only are siloed, but they've also been pitted against each other. And I think that if those two groups came to understand that they have a shared fate, that they have been harmed by similar kinds of systems, and if they mobilize together, I think we would end up with much better results. But instead, they're fighting over crumbs, and I think that's a mistake. Second, I think a big silo is that we're not looking at crises over time. And so the thing that I would urge people who are watching this to do is read history. Look back at the earlier drug crises, and you'll start to see the threads that carry through to our own. The mistake we make is thinking that every social problem is brand new. This is not new. We've been dealing with this for over 100 years. And whether that takes the form of opioid use in the early 1900s, or it takes the or marijuana use in the 1930s and 40s, or cocaine in the 80s and 90s, or meth in the early 2000s. Like, it doesn't matter what drug we're talking about, the same kinds of threads run through it. And so I think history is really incredibly important there. And then finally, I think one of the biggest silos, certainly between public health and the social sciences and humanities, um, has to do with how our work is funded. And so we're all struggling right now, I think, with some of the changes to federal funding. But I think what happens a lot of times with public health is the government says we really care about this issue, and so we're going to fund X. And then time moves on and they say, oh, actually, what we care about is Y. And so for public health, which often relies on soft money, they're having to kind of chase dollars that whose agendas are created by people who are not them. Sociology is generally on hard money, and so we have a lot of flexibility to study what we want, but we also tend to be more theoretical and less practice oriented. And so sorting through some of those challenges, I think, could really help sociology bring the theory and the context to the very applied, real world situations that public health is working on.
Yeah, I love that. Yeah, it's definitely going to have to be a group effort, right? So the more we can kind of speak the same language or understand each other, I think that's going to be our key to success. So looking ahead, what are some of the emerging threats or trends that you see that we should be preparing for right now? Jennifer?
Yeah, I mean, the short version, the short and pessimistic answer to that question is that because of the way drug policy and regulation tends to work in the United States, we're just going to be playing a game of whack-a-mole forever. First it was heroin, then it was fentanyl, then xylazine was scheduled, now it's getting replaced with medetomidine and so on and so forth. And so I think public health is very all too often treated as drug policy's Zamboni, expected to just kind of like come up and make everything like very nice and tidy and clean. And, where outreach workers and public health experts, like, I think probably all of my colleagues will agree that we're just doing our best trying to keep our heads above water and figure out what the heck is going on all of the time. But I wanted to offer an answer that's like slightly more optimistic as well in a trend that I see happening that I think is long, long, long overdue. I want to give a shout out to my excellent colleague on the call, Tony Locklear, and sort of lift up and celebrate the people of the Darkwater, also known as the Lumbee Tribe of North Carolina, who have very recently received federal recognition. It's a small piece of justice in the context of a wide absence of it, but all of it is overdue and very, very welcome. And I think that if all goes well, the future of harm reduction is going to be a deeply Indigenous future. Indigenous communities not only have, depending on how you count, between hundreds and thousands of years of uninterrupted culture and society on this continent, but also have been receiving, as was mentioned earlier, have been receiving truly the blunt end of the harms of substance use. Indigenous populations are among some of the most affected by overdose, some of the most affected by the negative social and physical consequences of substance use, some of the least resourced communities with less access to healthcare and social services, and it's places where feelings about drugs and people who use them can be very, very strong and very, very intense. And while they are places where I think innovation and beauty can really flourish, they're also places where stigma can be very high and fear can be very high, and for good reason. I feel exceptionally lucky to have burgeoning connections with the Lumbee community in North Carolina and other indigenous groups, folks in British Columbia. There's tribal nations in British Columbia that are running circles around the rest of us in terms of operating in really challenging, deeply affected, deeply like emotion-stricken environments and doing good work. I want to share a couple of resources that are example. One, speaking of groups in British Columbia, this truly one of the most beautiful pieces of writing that I have encountered in the last year by Sarah Littlechild, visioning towards a decolonized model of drug checking. And just recently, focusing on North Carolina and South Carolina. And Tony, I'm pretty sure you had a hand on this. So if so, good job, as usual. But Vital Strategies put out a document called Culture is Medicine that unpacks Indigenous models of harm reduction in practice and how Indigenous practices can become the sort of load-bearing pillar of public health interventions, and that rather than thinking about how do we transplant some of those like five, strategies that I talked about earlier into these communities, is like how do these communities decide to welcome those things into what already brings them strength and what already serves them very, very well. I think that we have an astonishing amount to learn. People like me have an astonishing amount to learn from Indigenous communities that are truly innovating, not just around interventions, but how to deliver the intervention, truly innovating around how to warm hearts and minds to interventions that can feel very scary to folks who believe that, illicit substances present nothing but harm and danger to their community, or who have experienced nothing but harm and danger as a response to the presence of illicit substances in their community. I think we have an extraordinary room for optimism. And as ironic as this is, I think that if we can shut up long enough to listen to these particular communities, that everyone stands to benefit fantastically from it.
Jennifer, and I appreciate you sharing those resources in the chat. At this point, are there any questions from the audience? We've got about 10 or so minutes left. Check the Q&A. Okay, well, feel free to drop those items in the chat if you think of anything. As we wrap up, do any of our panelists have anything else they'd like to share? Anything we didn't touch on? Anything you're like, oh, I should have said that earlier? Magdalena.
Yeah, just related to your last question, Nicole. I think for me, my biggest fear is that with the substantial decline we're seeing in overdose deaths in the past couple of years, that will be declared a success, and there will be a substantial decline in investment in resources to address this issue, right? In treatment and harm reduction and primary prevention and recovery. And I think for all of the reasons that were raised before about how this, this is not just a problem between the year it's 1999 and today. This is a much longer much longer problem if we take a historical perspective. I think that would be a big mistake. And I think, with if we see a substantial decline in investment in these evidence-based practices, we are going to see likely an increase in overdose deaths. And so that risk, as well as the current discussion that really focuses on supply disruption primarily and the role of law enforcement, raises a lot of concerns for me about what the future holds for us. So I hope we can, continue to place importance in the role of public health, in investment in prevention, and in having a long-term view about these issues beyond this particular opioid crisis right now.
Yeah, great point. I share your concerns about, kind of what happens next. And, we're just problem solved. We take away the funding, we change the policies that got us to these successes. It is very concerning. Dave?
Yeah, the thing I'd say looking forward is, to our statistically inclined listeners out there, there's a lot of publicly available data now that used to not be available. And so, Chicago's pretty good with putting up our data, but we can't post everything that we have access to. But there are a lot of places where you have a lot of highly accurate data on time and place. And so there's going to be the opportunity to do causal inference type work that is definitely not available, that was definitely not available in the past. And so, if you're out there thinking about how can I, as a statistician, do this kind of thing, I wish I had the time to do this kind of thing. My epidemiology is descriptive and trend wise, but there's a lot more publicly available data out there and coming out in places where those of you, especially my SAVIR colleagues, who have these hardcore academic credentials, that might be the time to say, like, hey, this is a spot for me in the broader story of overdose prevention and injury prevention.
Thank you. Liz?
One of the questions that I don't think you've asked, but that you left us with is what motivates us to keep working in this space? And I have to say, I'm a bit of a cynic. I am very critical of the healthcare system and I'm very critical of the criminal justice system. But it is a cynicism that's born of optimism. And it's because what I really want is for our institutions to work. I want them to do the things that they say they're going to do. I want healthcare to heal. I want education to educate. I want our criminal legal system to punish people who deserve it and rehabilitate people who can be rehabilitated. Like, I want our institutions to do what they say they do. And so I'm continually fascinated by what happens when they don't, or when healthcare punishes and criminal justice tries to treat. I'm really fascinated by the blurring of those boundaries, because I think we have the resources to do the things that we want to do, but we have devoted them to things that are doing harm. And so that's what motivates me to keep thinking about, why is this happening, so we can come up with better solutions.
Thank you. Right, seeing no further hands, I think we can go ahead and start wrapping things up. So I want to first thank all of our panelists for sharing their expertise, telling us about their important work that they're doing. And thank you to our audience for joining us and engaging on this really important topic. I hope today's discussion was meaningful for you. I hope it has you kind of thinking about ways to collaborate, ways to break down silos, how we can work across our various disciplines on solutions that can really help us to save lives. Please, when you exit the Zoom, be sure to fill out the evaluation. It'll take you to an evaluation survey. And Kristen, if there's nothing else, we can go ahead and wrap up.
Yeah, I just want to thank Nicole for moderating, and to all of our amazing panelists. This was the discussion that we envisioned having, taking evidence-based approaches across disciplines, talking to each other, bringing people into the conversation, and leaving with a hopeful message. I think Liz put it really well, that we do want to see our institutions and systems doing what we set out to have them do, and do the best by everyone. So thank you all for the conversation today. It's been recorded. It'll be up on our SAVIR and Safe States websites. And I just really want to thank all of our panelists for their time and expertise, and for all the great work that they do, and for all of our attendees. Thank you so much.
Thanks, everybody.